Over. I think Bridge was very, very generous in his compliments, and I think he gave me a lot more credit than I deserve. In fact, I consider Bridge to be one of my teachers. He was just one of my senior fellows. And actually, I've made trips to Bakersfield to learn things like carotid stenting from Bridge. So I'm very delighted to be here. What I'm going to do is try and give you an update on transcatheter valve therapies. And I just thought, let's see. I hope all these videos will work. So what you see here is, it mentions, it's not a typo. So it's a 100-year-old gentleman with severe aortic stenosis. And what I'm showing you is actually his right coronary artery and then his left main coronary artery. So his right coronary artery had a tight stenosis. His left main coronary artery has a trifurcation lesion. We fixed the right coronary artery, we fixed the left main, and we did a balloon valvuloplasty and we got him out of the hospital. But he came back, his stents were open because he had re-stenosed his valve. He was a robust gentleman, so in fact, very reluctantly, we thought we were doing ridiculous things, but very reluctantly we went ahead and actually did a transcatheter AVR on a 100-year-old patient. And these are, look at the gradients. There's a dramatic reduction in gradients. You look at the echo, the valve looks beautiful. And this patient went home in 2 days. And this is actually the tall gentleman is the 100-year-old patient. He's 1 week after his procedure in my office. And his buddy on the other side, not the other one, is actually a 97-year-old gentleman who had TAVR done 2 years before him. So, so you'd ask me, so what happened to this 100-year-old guy? And actually 3 years later, a few months ago when we had an ACC program for TAVR, he was actually there. So he's still alive and actually doing well. So I just thought I'd start with some cases that we do in our lab, and I think I have the luxury and I have the good fortune of working with many, many good, talented operators, one of them being right here, Saibul Khan, and of course Amir and I also worked together on some of his cases. So here is another gentleman. So together I think we can break a lot of boundaries and do a lot of things. So here is an 84-year-old gentleman who actually doesn't have aortic stenosis. He's got aortic regurgitation. He's an extreme risk patient, and in this particular patient we were able to go ahead, put in a electronic core valve and actually treat his aortic insufficiency. So there's an example of this. Now here is a patient where we had performed a transapical transcatheter aortic valve replacement. But what he had as a result of his transapical access is a pseudoaneurysm. So you can actually see that there is this pseudoaneurysm that actually communicates with the LV cavity. It's a very serpentinous tract. So we first tried to go through the LV. We couldn't actually do it. So just using a micro puncture needle and a micro wire, we just punctured it directly under fluoroscopy. We were able to advance catheter. So we turned it through the neck of the aneurysm and put a 6-French sheet. And then we were actually able to put in a plug, as you can see, and actually seal this aneurysm. So these are the types of things that are actually occurring in the cath lab. Now here is another gentleman who had a transapical transcatheter TAVR. All right, so you can see that there is a TAV valve there. He also had a mitral bioprosthesis, and this bioprosthesis was actually severely leaking. So once again, we re-accessed the apex in this particular case, and we were able to deploy a valve in a bioprosthetic mitral valve and actually take care of this. So here are the pictures. Once again, you can see severe mitral regurgitation on the upper left panel, and then look at the valve that has been placed in the valve, and look at the 3D images. They're so spectacular. Once again, this transapical access is always tricky, and at times the apex can melt, and you can be left with a patient with a successful procedure and not a very successful outcome. But I think if you can manage the apex well, this procedure takes a very short time. So here is another patient now. So I'm just trying to give you a flavor of different cases. So this patient had a stentless bioprosthetic valve. All right, so this is called the St. Jude, Toronto valve, and it doesn't have a stent, unlike other surgical valves. And this patient had severe aortic insufficiency, and we didn't have a surgical choice. And once again, as we were analyzing this case, we realized that the left main coronary artery is very low. And the obvious challenge here was that if you put a valve here in this valve, it's going to basically compress the left main. So we went prepared, in fact, here. What we did was we protected the left main. So you see a guide catheter there, in addition to the, there are two guide wires. And what you also see is actually a stent. There is a stent that is not deployed, but positioned in the left anterior descending artery. All right, so this is all preparation in case when we deploy the valve, if we get in trouble, we'll actually use it. As soon as we deployed the valve, you can see what's happened to the ostium of the left main coronary artery. In fact, it was very dramatic. Okay, so this patient's LV became stunned, but very quickly, all that we had to do is we didn't have to struggle to insert a stent in the left main because we were prepared. All right, all that we did was pulled back the stent and deployed the stent in the ostium of the left main, compromised left main, and we were able to actually bail this patient out. And the patient went home 2 days later, and almost 2 years out, she's doing spectacularly well. Her ejection fraction was 20%, and she had suffered for months because we weren't sure as to kind of how to do this. And LV function is actually dramatically improved and is more than 45% now. Here is another patient. This is a patient with a failing homograft. He had Bental surgery in 2004, and he's very high risk. So, once again, we did the CT scan. There's practically no calcium. All right. So what we were able to do here is use a self-expanding valve. All right. Unlike the previous case where I showed you the balloon expandable valve, here is a self-expanding valve. And once again, we protected the left main coronary artery. And, as you will see, the valve is deployed. And look to the right, there's actually 0 AI. So this is a very, so yes, of course, but increasingly we are using this even in AI. And I have to say the results are not as good as aortic stenosis, and you have to properly size, otherwise you can actually end up in big trouble. But this is something where we are pushing the limits. Now, moving away from the aortic and mitral, so just a case. This is a patient where, in fact, many years ago, in 2009, Saibal and myself, we actually did a pulmonic valve replacement. Okay, so we enrolled this patient in the compassion trial, and he had severe regurgitating pulmonic conduit. We put pulmonic valve in him. He did okay, and over the years, he actually developed severe tricuspid regurgitation. So that's actually after deploying the pulmonic valve. It looked very good, no pulmonic insufficiency. This is severe tricuspid regurgitation that we noticed over follow-up, over the years. And once again, what we did here was actually took a balloon expandable valve and deployed this in the ring. So this ring was in place, which actually allowed the anchoring of this valve and allowed us to take care of the tricuspid regurgitation. Now, the tricuspid ring is not circular, the valve is circular, so of course we were left with a little bit of paravalvular leak. And what we did was we went ahead, we crossed the paravalvular leak and plugged it with an anaplastic device. So things are very dynamic in the cath lab now. With the foray into the avenues of different areas in the structural heart disease, there is practically no limit. Now, here is another patient who actually came to us from Vegasville, 94-year-old gentleman. So his ejection fraction was 20%, and that's an optimistic assessment. He was turned on by 2 surgeons, but he was very, very alert. Actually, he was a retired physicist, father of one of the physicians here, in fact. And you can see there's a left main stenosis, the right coronary artery is included, and he had tight aortic stenosis. In this particular case, we first did a balloon valvuloplasty, then put an impeller device in him to support him a little bit better, then went ahead and fixed his left main stent, and then we brought him back and actually did his TAVR procedure. So, just a little bit of a flavor. Now, I think what I wanted to point out is that the PCI volumes are basically not growing much. And if you look at the growth that is occurring globally, it's mostly outside of the United States, not in Europe. It's actually driven by China and emerging markets like India and maybe somewhat in other developing countries, where PCI is not penetrated. On the other hand, if you look at what is going to happen, what is the potential with the transcatheter valve devices, the companies are very excited, because in fact what they see as a potential, and what they see what is actually penetration right now, there's a significant delta, and that is where a lot of growth might be. And this is just a slide looking at the worldwide market revenues of these things. Of course, a lot of this will come from expansion into new geographic locations, but a lot of this is actually from expanding indications. So, for example, TAVR, which started off in high-risk and inoperable patients, is now being tested in intermediate-risk patients, and will actually likely be used much more frequently. So a little bit of what I thought was, let me give you, so I showed you some pictures, let me show you some slides. So here is just a slide of what one could argue may be partial depiction of devices, transcatheter valve devices. And I think this could pose a significant conundrum for us operators, not very different from our wives when they go to a shoe store, right? So let's talk about different aspects. Mortality benefit first. What is the data of mortality benefit? And some of you might know the design of the partner trial. There was the inoperable cohort and the high-risk cohort. And if you look at the data in the inoperable cohort of patients, what you see here is that at 5 years, if you look at the difference between patients who were treated with a valve versus patients who were treated medically, it's actually astounding that even up to 5 years in this patient population, there is a benefit in survival. All right, so the median survival was 11.1 months in patients who were not treated with a valve, compared to 30 months almost who are treated with valves. And if you look at the cardiovascular mortality, there's actually a big difference as well. So this is primarily driven by cardiovascular mortality, and there is benefit despite the fact that these patients were actually quite old. What about comparison to surgery in high-risk patients? So this is the data, in the partner trial. What you can say is that compared to surgery in high-risk patients, the SAPIEN valve was equivalent in terms of survival at 3 years, and the 5-year data will actually be presented at the ACC in March. And this is the landmark analysis, which shows that the outcomes were similar at different time points. But a study which I think is very important, that has really moved the field of TAVR forward, in addition to the inoperable cohort study that I mentioned about, is actually the core valve study. And that's because in the core valve study, what we saw was there was actually better outcomes in terms of survival in TAVR patients compared to patients who were treated surgically. And it's not because of the valve. It's because the field moved forward. We knew how to use these devices. We knew how to size these valves. There was no transapical access in the core valve study, which clearly has worse outcomes when you compare to transfemoral. But I think this was a very important study which was needed. If the results were the other way around, I can assure you that we would actually be struggling today. So I think we all owe a debt of gratitude to the people who actually did the study. So yes, the life is prolonged. What about functional survival, functional benefit? So here is the data. People who get TAVR compared to no TAVR actually stay out of the hospital. All right, and their functional class is better, as is actually shown here. All right, so NYHA class is significantly better in patients who get TAVR device. How does it compare to surgery in these patients? So if you compare, once again, the outcomes or the NYHA class is better in patients who get the valve through transcatheter technique at 30 days, because these patients can actually mobilize faster. Now at longer term, at 1 year and 3 years, there's no difference between the two groups. And these are some of the sophisticated quality of life questionnaires that have been developed that actually clearly favor TAVI over control. So this is not just prolonging the lives of patients without a meaningful impact on quality. There is actually a meaningful impact on the quality. But for these studies, I can assure you that we would all be criticized today for bringing in the 95-year-old patient that I showed you and the 100-year-old patient that I showed you. We would actually be called crazy. So what about, do these valves function? Yes, actually, if you look at the data, here is 5-year data on durability. The areas are up and they actually stay up. The gradients are down and they actually stay down. And this is just looking at different cohorts. Once again, in fact, this is comparing it with surgical aortic valve. No, I don't think we need to make a claim that TAVR results in better valve areas, But what we know is that when you do TAVR, you can generally put in bigger devices than what the surgeons can do when the heart is collapsed. So I think that it is reasonable to say that we need to acknowledge that we don't have 10-year durability data like some of the surgical valves, but at the same time, I think we can take solace in the fact that the data actually look encouraging, and in the valve areas at at 3 years don't appear to be worse than surgical valves. And these are just some of the other studies using the core valve. So what about valve failures? Have we seen any? Yes, we've seen occasional valve failures, but I can tell you these are actually rare. The bigger problem is that of paravalvular aortic regurgitation, not of degenerative process that affects the valve leaflets. There is actually a recent publication, 87 cases of valve failure from the literature, considering that there are almost 150,000 or 200,000 TAVR procedures now done globally. These numbers are rather modest, in fact, if you look at. But I think what we're beginning to realize is that subclinical valve thrombosis may actually be an important thing, and perhaps drugs might be relevant there. So let's talk a little bit about complications. So let's talk about stroke. I think what we know is that the stroke rate goes up very quickly after TAVR procedure, and this is comparing it to no procedure. I think we have to acknowledge that. This is comparing it to surgical aortic valve replacement. Okay, so early on the stroke rates are higher. If you follow them up to 3 years, there was no difference in stroke rate. So I think what I take away from this is that the valve is not a continuous source of emboli which causes stroke, and whatever you want to make out of 3 years, the stroke rates are similar between surgery and TAVR. But what was very interesting is that in the core valve study, the stroke rates were actually higher with surgery than they were with TAVR procedure. And some of this is a reflection of a better screening, and also because of the smaller size of the catheters that has actually occurred over the years. And I think largely, I would say, also very aggressive or more balanced monitoring of strokes that was actually done in this particular study. If you look at overall data, I think it is reasonable to say that the stroke rates are about 2%. So I think that I would argue with the surgeon when the surgeon would tell a patient in high risk that the stroke rates are higher with TAVR now. But I think, having said that, it would be wrong for us not to fix this problem. I think this problem needs to be fixed. And one of the major developments is actually cerebral protection devices, which actually, for example, this is a small study that was presented recently at TCT called the Clean TAVI study. So these are filters. And what these filters, when used in conjunction with TAVR, did was reduce the number of emboli into the brain. So there was a reduction in the total lesion numbers as assessed by diffusion-weighted MRI, and also total lesion volume, as was seen. And there was actually trends in terms of benefit in subtle neurologic dysfunction, such as gait dysfunction. So I think it's not just always about frank strokes, it is about the subtle neurologic findings such as instability in gait. And I think this is going to become more important. We're starting a larger study of about 500 patients where we're going to be randomizing patients with TAVR procedure with and without filter. So I think that it's possible that this will be the standard of care if these results are actually proven to be true. Paravalvular AI, as I mentioned, is an issue, and it can occur in about 10 to 20% of cases. But the good news is, and it is important because it's not just a picture that, it actually matters in terms of survival. Greater the paravalvular AI, greater is the impact on mortality. And in fact, this is a slide that comes from the Partner 1A trial. And what this shows is, if you take patients with TAVR who had no paravalvular AI, and if you compare them to patients with surgery, TAVR actually beats surgery at 1 year. So which means that if you can overcome the issue of paravalvular AI, you stand the chance of being very competitive with surgery. And I think that is what needs to be done, or should be done, before we expand indications or test out devices in lower risk patient population. And some of this paravalvular AI clearly came because we didn't really understand how to size these. And this is in 2011, only 3 years ago. And if you look at this, you look at the annulus, which is where the valve sits, it's actually oval, it's not circular. So we were measuring wrong things and putting wrong size valves, and then we realized, and one of my colleagues, Dr. Jalabi, actually did some of the pioneering work of using CT scan and properly sizing the valves. We were able to show that we can reduce paravalvular AI very, very significantly. And this is now the standard way that we do TAVI today in 2014. You can reduce paravalvular AI by what is called post-dilatation, but it's not always a good thing to do so because it can increase stroke rates. So there are newer devices, such as the SAPIEN 3 valve, which has got a little skirted bottom. All right, and what that does is basically reduces paravalvular AI. As is shown here in this particular study, the incidence of significant paravalvular AI was dramatically down. In fact, there was not a single case of severe paravalvular AI and only 2.6% moderate paravalvular AI. So I think we've made significant progress. Vascular complications are actually down. In our lab now, the vascular complication rates are clearly below 5%. In fact, severe vascular complication rates are more like 2 to 3%. And this is earlier data from Vancouver that showed a dramatic reduction in vascular complication. Conduction system is still a little bit of an issue, especially with self-expanding valves. If you look at pacemaker implantation rates, they can be anywhere up to 20 to 35%, depending upon the series. So balloon expandable valves, less likely to require pacemaker, about 5 to 7% of the times. Same thing with left bundle branch block, more common with core valve, less common with the balloon expandable valve. And so what is the relevance of a left bundle branch block? Well, what we know is that it doesn't affect mortality. It occurs about 10% of the times after TAVR. What we also know is that it is a predictor that you might need a pacemaker at follow-up if you have a left bundle branch block. And what is also very interesting is that if you have a left bundle branch block and if you had low ejection fraction, you can actually not increase your ejection fraction. So it's not a very good thing to have a left bundle branch block if you can avoid it. And I think these are areas, so this is actually data comparing left bundle versus new left bundle, and patients who developed new left bundle did not increase their ejection fraction. And this is just looking at permanent pacemaker implantation rate, and once again another series that shows that there is no impact on survival. So TAVR indications are expanding, and actually I showed you a case looking at valve-in-valve. So this is some data. So this is, once again, earlier experience, and if you look at the 30-day mortality, it was 7.6%. I think we are doing better now, okay, than what is published here. What we also know is that when you do a valve-in-valve procedure for stenosis, you are actually going to have worse outcomes than when you do it for bioprosthetic aortic regurgitation. And what we also know is that if you put these valves in smaller valves, if you have a 19 millimeter valve and you put this valve, you're going to be left with gradients. Maybe the better thing for this patient is to have another surgery where the surgeon can enlarge the aortic root and put a bigger valve. So I think that and there is no difference between balloon expandable or self-expanding valves when it actually comes to treating valve-in-valves in terms of overall outcomes. So a little bit about, just a couple of words about, patient subsets. And not presenting data because of shortage of time, but there is data that outcomes of TAVR may be better in women than in men. And that may just be related to the fact that in the earlier days we had only 2 valve sizes available, large sizes were not available, so more males were actually left with aortic regurgitation compared to females. And as we know that paravalvular AI affects the outcome. So impact of coexisting coronary artery disease is not fully defined yet. Now, what is it that the patient undergoes TAVR for? That also determines the outcomes. So, here is a paper that we published, and basically this looks at technically inoperable patients versus patients who were clinically inoperable. So somebody who had a porcelain aorta is technically inoperable, and doesn't have a lot of the comorbidities, for example, and those patients have low STS scores, and their outcomes are dramatically better than somebody who's got COPD and a lot of other comorbidities with a very high STS score. Diabetics, they do better with TAVR compared to surgical AVR. This is a sub-analysis from partner trial data, and I think we need to analyze this more, in a larger cohort of patients, but the data are actually quite intriguing. Should everybody get TAVR? I have to say that at times I'm left scratching my head when all these people are sent to me. And what we know is that as you have increasing comorbidities, okay, it is, as Michael Mack said, or says, it is important to recognize patients who are dying from aortic stenosis from patients who are dying with aortic stenosis. And this is data that we actually published in the 2-year analysis, and basically what it shows is that the STS score goes up, all right? So which is, if you have a lot of comorbidities, your benefit actually goes down. But what was very striking, this was at 2 years. At 5 years, that doesn't really hold true. So, you know, there are some people who will die off early on, but the survivors, you know, so at 5 years, in the 5-year analysis, there was still some benefit. So I think the important thing to recognize here is that just a single metric like STS is not the only way to look at patients. We have to look at the patient as a whole before we decide to go ahead with this expensive and somewhat invasive therapies. The other thing is that we can do these valves not just through the femoral artery. We've done them through the subclavian. We've done them through the apex of the heart. We've actually put valves, you know, with Amir's help, going down people's carotid arteries. And you can actually go through the inferior vena cava, puncture into the aorta, and actually go to the other side. So you can get these devices in one way or another now. But what we know is that it is the transfemoral access that has the best outcomes based on some of the analysis from the partner trial. So the intermediate risk studies, you know, the studies looking at these devices in lower risk patients were done. And the partner trial is complete, and in fact, we might have 1-year data at the coming ACC, though the primary endpoint is 2-year. And the study in intermediate risk patients with the core valve called the CERTAVI, in fact, is ongoing, and we'll have data from that as well. So I think, I hope I've given you, as far as TAVR goes, a flavor. I think we've done well with mortality benefit and functional benefit. The data with durability is gathering. We've solved the issue of paravalvular leak to a great extent. I think stroke we have some solutions for. I think vascular complications are dramatically down. And as you can, and I've presented data to you about the expanding indication. So very quickly, I'm going to just touch upon, mitral regurgitation, which is actually clipping the mitral valve is Seibel's specialty. So this is, we all know that mitral regurgitation, of course, surgery is the gold standard. But we also know that a lot of patients actually are not surgical candidates. And we also know is that when patients are managed medically, they end up getting readmitted and dying at very high rates. So basically, this is a subset of patients where if you had an alternative, they would actually do very well. And one therapy that is approved now in the United States is actually the mitral clip therapy. And what I'm going to show you is just the first study that was done called the Everest 2 study, which was a randomized trial between surgery and mitral clip. And what I want to point out here is that the freedom from death was the same compared to surgery. And the caveat here is, this was several years ago, in fact 9 years ago, when we didn't know how to use the clip, when we were allowed to use only one clip. Even at that time, if you look at freedom from death, it is actually quite similar. Things have changed dramatically in the E-clip. Yes, freedom from surgery and reoperation was better with surgery in this cohort of patients. And mitral regurgitation was significantly reduced in both. And yes, of course, when you did surgery, the improvement was actually somewhat better. The reason why E-clip was approved in the United States was because of the realization that a lot of these patients out there that actually need some therapy, and in fact, in this controlled matched analysis that Seibel and his colleagues performed, basically what was shown is that patients who underwent E-clip procedure, there was better survival. This was not a randomized, this was actually taken from the database, but still, I think this was enough for the FDA to actually approve. And I have to say, it's a very elegant procedure and dramatically helps our patients. The worldwide experience with E-clip procedure has exceeded 18,000 patients now, in fact, around the world, it is being used 2/3 of the times for functional mitral regurgitation. In the United States, a very important study is underway for functional mitral regurgitation, which is randomizing patients to E-clip versus control therapy, and this is where patients undergo aggressive medical treatment by actually heart failure specialists, such as Jake Patel or clip procedure. Something that is on the horizon is actually mitral valve replacement, and there are obvious challenges, unlike the aortic valve, because it's large, it's asymmetric in shape, there are no landmarks, and the closing pressures are actually higher. And there are 3 devices which have some early experience, Fortis, Cardiac, and Tiara, and this is the Tiara device, which actually is unique in that it has a natural D shape, compared to the native mitral valve annulus, and it's designed so that not to impinge on the LVOT, and these are some of the cadaveric experiments showing how this valve actually sits in the mitral valve. There are 3 cases that were done in Vancouver, and the first case took 20 minutes, the second case 12 minutes, and the third case actually took 35 minutes. So this is, once you have good transapical access and the right patient selection, this is actually not very difficult. And here is an example of this, so this is the severe mitral regurgitation in one of the cases. And this is, once again, transapical deployment of the TRR device. There is a wire in the coronary sinus which defines the annular plane. It gives you some landmarks, and this is after the release of the device. And these are the echoes. You can actually see that there's no mitral regurgitation post deployment. So I think these are early studies. They're very, they look very enticing and exciting and promising. But I think these therapies will have to compete with some of the approved therapies, at least at this time. So here is actually a 3D picture of the mitral valve. In the post-TRI, you can see the D shape, and you can see the nice closing of this valve. Fortis is the Edwards device, once again a self-expanding bovine pericardial valve, and the experience has been somewhat humbling, but actually somewhat improving now as the device has been used in more patients, and this is yet another device called the cardiac, which has been used in a few patients as well. So I just thought I would end my talk by showing 2 of my favorite cases, and I think I say favorite cases because they just demonstrate the synergy that we have created, at least at our institution, by using this technology. So here is a patient that we did his bicuspid aortic valve. In fact, we did this case live. In fact, also stented his left main, and so the valve looked pretty good. So the post-DAVR valve looks good. The gradients were actually very low. This patient did well, and then in fact came back with severe mitral regurgitation, as you see. So this is a case that Sadal and myself, we did this case 2 or 3 days ago. All right, and we put a clip in this patient. All right, so as you can see, there's a clip there, and the mitral regurgitation is gone. The patient went home the next day. And finally, one more case. This is a patient that Sadal likes to call from hospice to Costco. A 93-year-old patient, once again, who had critical aortic stenosis. And as you can see, post-TAVR, the gradients are down. This patient had persistent mitral regurgitation, which does get better in about 3/4 of the patients, but if you have something like a flail leaflet, mitral regurgitation is not going to get better. And once again, in this particular case, patient underwent a clip procedure, and there are 2 clips that have been placed with resolution of mitral regurgitation, and the patient actually went shopping to Costco. So I think I can say that modern technologies have allowed us to do some amazing and some, I would say, almost ridiculous things. Taking patients from a hospice and sending them to Costco to shop. Thank you.
Thank you, Raj. Incredible work. It reminds me of turn of century, 19th century, the guy who was running the patent office of US, he said, we need to close the office because all that's patentable has been discovered. So it reminds me of my journey in cardiology because see Tommy Lee here, see Dr. Singh here, Bill, Nitre. We started doing cats with 8 French catheters. And it's amazing, we never use 8 French catheters for complex procedures now. And we thought we attained the highest achievable mountain a long time ago, and we keep finding newer territories. So I think this patent office stays open. Let's come back, we have 5 minutes. So yes, now actually I'm working on speed waiting. So I already finished for 40 minutes in 10, so we have 5 more minutes. So any questions, please?
How would you define intermediate risk?
So the intermediate risk is defined the way the clinical trials. High risk was defined as STS more than 8. So when you have a patient, you can go to the STS website. You can put in all the age and all the other comorbidities, and it'll spit out an STS score. Now, so what was traditionally defined is that more than 8 was actually high risk, and more than 4 is considered to be intermediate risk. Having said that, I have to say that STS calculator has its flaws. Over the years, You can take the same patient, and 5 years ago when you put that patient into the old calculator, you would get a score of 8 or 10. And if today you put the same patient into the calculator, because it keeps changing, the calculator keeps changing, because the sickest patients are they don't enter into they are not undergoing surgery. So you will actually get much lower STS scores. But to answer your question, STS of 4 or more is intermediate risk.
How does it increase your volume or increase access to that?
So we participated and we did the intermediate risk study, which was the partner trial first. We are doing the CERT-HAVI trial. In the partner trial, between the partner trial and between the partner trial and continued access, we enrolled almost 250 intermediate risk patients in the last two years. So that tells you. So it dramatically increases your access to TAVR if the intermediate risk categories are going to, if it will be approved. And first, before it is approved, you have to show that it works.
Who are not candidates for that's not candidates.
Who are not candidates? I think young patients who are good candidates for surgical aortic valve replacement should not undergo TAVR. That's number one, because we have no data. All right? And if today you did that, your hospital would be violating the Medicare contract that they have, because you have to follow the CDS guidelines. Now, that is not to say that some 70-year-old rich person comes to you and says, I'm not going to charge my Medicare, I want you to do my procedure, and you can do it out of Medicare. Are you allowed to do it? You're allowed to do anything as long as you don't bill it to Medicare. So, but I think that the right academic and the right data-based answer is that we have no data in these patients who are young and who are good candidates. I think that we should go step by step. I think we started with inoperables and then high risks, and we did clinical trials in intermediate risk. I think we should do a trial in all comers. I think the technology has evolved now. We've taken care of paravalvular leak rates. I think we should use distal or cerebral protection devices if they're shown to be effective. We could make the argument to use them anyways now, given that they were shown to be effective at least in one small randomized trial. And then do the study in all comers, which would include the young, low-risk patients. But that should be done in clinical trials. And patients who have severe multivalvular, so if you fix aortic valve, and if you're going to still leave that patient with other valvular issues, you shouldn't do it.
And they are on a lifelong anticoagulation after this.
So the data is, the trend with core valve was to give aspirin and Plavix for 3 to 6 months, okay, based on some of the data that came out of Europe. There is no fixed guidelines as to how to treat, because some of these patients are really old and frail. So if you start giving aspirin and Plavix to some people who are 95 years old and 90-year-olds, it may be counterproductive. But there is some interesting CT data that we have accumulated that might suggest that if you were to expand this to lower risk patients, perhaps these patients should be on Coumadin for the first 3 or 6 months, just like we used to do with surgical bioprosthetic valves. But I think the right answer right now is there is no fixed guidelines or recommendations.
Hi, I'm Dr. Gopal. I have one question. You showed the mitral valve clip. How old is the patient, and was she in atrial fibrillation? And will that procedure, mitral valve clip, will be applied to younger patients too? What is your opinion on that?
So I think the 2 patients that I showed you, one of them was in her 90s and the other patient was actually in her 70s, 78, 79, but with a lot of other comorbidities. Those are the 2 patients that I showed who had both TAVR and mitral clipping procedure. Now, the youngest patient that cycle was done, with E-clip procedure was 26 years old. 26 years old, and she is now 6 years out. She's 6 years out, she had Barlow syndrome. Now, clearly, the data showed that we were not as good as surgery with clipping, okay? So I don't think anybody is making the recommendation that we should be using this clipping procedure in young patients who have degenerative disease, who are otherwise good candidates for surgery, including robotic surgery. You know, Alfredo Trento does a beautiful job doing, using robotics in some of his young patients. So that's not it. But I think the bigger pie may be these functional mitral regurgitation patients who don't have the surgical option, okay, and who can actually benefit. Yes, we need to do the COAP trial, but the rest of the world has really caught on. As I showed you, 2/3 of these patients out of 18,000 patients are functional mitral regurgitation. So I have European colleagues are not, they're smart, right? They're treating some of these patients and they're keeping them out. Of course, in America, we'll have to do the COAP trial and prove that that is what really needs to be done.
I saw the picture.